To be able to share my screen.
All right. Now I'm looking. It's not allowing you.
Nope.
All right, 1 sec. All right, see if you can do it now.
No can do. Yeah, it still just has me listed as a participant.
Just listed you as a presenter.
I wonder if I have to back out and then get back in. Nope. It's still dark.
Awesome. Well, I appreciate everybody's patience while we sort this out.
There we go. Got it.
Perfect.
Woo. That's all right. I'm used to Zoom, so we'll see how bad I can mess this up. All right. And let's make sure this works. Can you see my screen?
Yes.
All right. Here we go. All right. Thank you all. So this is, man, we got like 30 minutes. So interpretation, integration of Digitsole's movement analysis in the clinical setting is it's a bit beefy for about 30 minutes. So that's why technically it's an introduction. Thank you, Josie. So I'm director of education with Digitsole. So my job is to hopefully bridge some of the gap between the information presented by the manufacturer and then with clinicians. So what we want to cover in this 30 minutes, and that's my common icon of eye rolling because I'm not known for my brevity. So there's always an over under on betting on whether I make it. So quick introduction, then we'll get into human movement analysis, really with the emphasis on gait, a little bit about the technology, and not to PowerPoint you to death because I really want to spend most of the time going over the analysis and really the summary. So where does it fit? Where have I been using it, and so on to implement it within clinical practice. So quick overview of the organization. And so Digitsole, so since 2015, so they've been developing health-based platforms, including wearable sensors. And most all people are familiar with the fact that wearable sensors are highly utilized to provide all kinds of information. And if you were in school and you were in school at a time and at a facility that had a lab and even what some people utilized after school, being able to utilize this as a form of information is a great way to kind of look at what's going on with people, and we'll get into more detail with regards to that. But Digitsole kind of took it a step further, and I've been so impressed with the type of information that they're able to generate. And part of this introduction is looking a little bit about my background. So I've been using gait analysis in the clinical setting for about 12 years from a technological standpoint. I've always used it, through more of a qualitative analysis, but then, being in higher education for a good part of my career, I had experience using a lab. So I ran a biomechanics lab. I ran two biomechanics labs. So full gait analysis, peak Vicon motor systems, AMTI force platforms, and so on. And then at the clinical level, I think one of the challenges we always have is how do we bring that down to a point where it's easier to access the data and make it translated into, well, how do we use it in the treatment of patients? And that's where I think what you'll see with this kind of stuff is it really allowed us to bring it down to that level. Like, even if you follow like the National Strength and Conditioning Association, they've got a new certification coming out called the Certified Performance Sports Scientist. So sports science or science implication into the clinic setting it's not new, but really it's starting to reach its peak because of the quality of information, the cost of the devices that are utilized, with our ability to access these things that we used to just be able to use in a laboratory setting. So, why do I use gait analysis? Well, it's kind of the insight into the soul of human movement, right? So if you work in physical medicine, or even mental medicine, the end of the day, as a species, we are designed to move. And you can look on any TED Talk or Google anything, and you find that there's so much association to how it is that we utilize human movement to maintain health, to prevent disease conditions, and then to treat it. So those of us in the physical medicine conservative space, that's a big part. And at the end of the day, what are we trying to accomplish? We're trying to get people to move better, because that's associated with, getting them better overall in life. So we utilize human movement analyses to determine, what type of condition, looking at the course of a pathology, and depending on the systems that you're using, the approaches that you're using in the clinic, they have relative sensitivity. So they may even lead us down a path of determining exactly what that diagnosis may be. But again, that's still, part of that health or wellness perspective, but in the physical movement. So we really look at it in terms of the disabilities, and that's what we manage, right? So we don't really treat disease conditions as much anymore as we do, kind of manage them. I learned over 20 years ago, a low back pain patient is always a low back pain patient, because if there was a disruption to certain anatomical features that you're not going to get back, then there's always going to be something that you're going to have to do to maintain that, let alone just the effects due to aging. The other thing that assessment allows us to do is determine the effectiveness of whatever it is that we're doing in the clinic, right? If I'm doing these exercises, if I'm doing this particular physical agent, or what have I given the patient to do at home, is it working, right? Because we have these outcomes based data categories to determine, well, whether or not something is working, and even certain normative data that allows us to look at the level at which they've achieved. And sometimes we refer to that as sort of this maximal medical benefit. But our limitation. So in the clinical setting, and this is identified across the board with all kinds of physical agents and other tools that we utilize beyond of really what we learned in the clinic, is, is it time effective, and is it easy to interpret? So the limitation in not having enough time, because let's face it, one of the things that influences some of our patient care, hopefully not all of it, but is the reimbursement, and how do we get paid? And it doesn't matter if you're looking at reimbursement by third-party payers, or that shift in the financial responsibility of the individuals, but we need to. It's still, it's an industry, it's a business, and it's the business of health. And so we need to make sure that, we're time effective in managing our patient conditions, because you need to treat enough patients to generate enough revenue to keep the lights on, pay for your malpractice insurance, so you can care for as many people as possible. So there are factors associated with why we're going to implement something, and they're not just tied to a revenue stream directly, but maybe indirectly. Is it time efficient, right? Does it provide me the information that's necessary for what it is that we need to accomplish with the patients that I actually serve? So what was interesting is looking at this technology, and well, it's really small. It's highly reliable and valid. It's easy to implement because the time course to do an analysis, a gait analysis, and I want to clarify that and use that again. A lot of people throw the term around gait analysis, and the assumption is, like many of us that we learned in school, it was really kind of directed towards, what was going on with a low extremity condition versus, well, what exactly does it do? What kinds of things are associated with changes in gait? So gait is sort of the look into the soul of overall human movement, because it's highly reflexive as well as a high voluntary component to it, and the essence of what people do on a very basic level throughout most of the day being in that erect posture position. So it's a really good look at to what is going on inside of the patient. So having this information at our fingertips, what do we get with this? Well, it's an artificial intelligence and motor learning platform, and that's a fancy way of saying it's constantly evolving. And as the data is collected by the various practitioners, all the PHI, the personal health information, is not shared. The organization doesn't even get that. But what it does is it helps to continuously develop the algorithms that are used to enhance the benefit in how the system actually works to look at human movement. In fact, there's probably as much data that's been collected by these guys as probably put together a lot of the lab systems in academic research centers. So it's a very sophisticated algorithm, but it's really software driven. So what they've done is they've done a great job at keeping and minimizing the hardware in terms of the complexity of it, and making it software driven. And what we get from that is we get the constant updates and the changes that are associated with that artificial intelligence and motor learning. And then they've done a really nice thing for us is they've taken all that information and really consolidated it into a format that is designed specifically majority wise for clinicians. You can get fancy if you want, but it's really brought down to a level at which we see that as clinicians, I can show this to a patient and make it really understandable, right? It's a cliche. We see it in movies, TV shows. The doctor tells them something and they're like, just tell me in English, what does that mean? And so we're able to actually do that. And that's what's been consolidated. So looking at the software component, we collect the data via mobile devices, and so it's compatible with iOS, so your Apple products as well as Android products, and that's a phone, that's your tablets, that's your iPads, and things like that. And then it has a computer-based application to it, which is it's cloud-based, so I can access it, anytime I'm on any computer. I just log into my system. So cross-platform, but all the data is shared. And I think what's especially cool about that for someone like me that likes his tech, so I have, two different phones that are iOS, I have an Android tablet, and then I have three computers in my lab/clinic. So I can get online and within seconds I can access a data analysis that I just took. So oftentimes I take that in one room, I go into the other room when I talk to the patient and pull that up on the computer to actually show them the data. So the computer profile is a little bit more robust than what you see on the app, but the app is great because it's the perfect visual to actually be able to show patients and other people, what just happened with their particular walking pattern or running pattern. But then I can get on the software on the computer, and I can do a little bit more. I can do some comparisons between two different tests. I can do an evolution. So if I'm following this patient And because it only takes me a couple of minutes, I can take an analysis, once a week or every 4 visits or whatever it is that you decide, and it actually plots that evolution from start to finish in a graphical representation that I can actually overpoint and even show the patient or another person if necessary. And then also from the software online on my computer, I can export that PDF file to the patient or to their coach or to another practitioner if I'm referring that patient to somebody else. So the views that we see on the mobile devices give us a lot of that information, really simple and easy to be able to have that really quick discussion with a patient. And then if you need to get a little bit more robust, you can get online and evaluate some of that information. So the analysis itself, and this is kind of where I wanted to spend most of the time, is so that's the information that was collected, and then it's computated. So that information is collected with your device. It goes up to the cloud, computations take place, and then it sends it back down. And I want to say it's like 15 seconds. I know someone probably knows the exact amount of time, but I found that that's the amount of time it takes for me to walk from one room to the next, and it's already up. So I don't even have to wait for it there. And it's everywhere. It's on all of my devices at the same time as soon as I turn that on and upload. So on the analysis, it provides us basic information on the dashboard that allows me to choose the various patients. We'll go to this in a second. Choose the various patients and then pull up their analysis. And then from the analysis, it shows me, across the top, one of the most basic things, which is going to be symmetry with regards to how the patient is actually moving. And then it has a breakdown of the basic gait parameters, which again, I think these are the things that everyone remembers from school when they were taught basic analysis when it comes to gait evaluation, and probably some of the things that we may try to replicate in a clinic, either with some grids on the floor, things like that obviously is a little bit more qualitative than just looking at them. So contact time, stride, flight time, those really basic, all that stuff is just right there up on top and is really simple to look at and evaluate. And then, oops, gait, that's supposed to be gait line. So the gait line is looking at the center of pressure pathway as we go through the various components of the footstep. Propulsion rate is looking at the strategy in using your hip flexors and plantar flexors as far as initiating that swing phase. So that's important because it gives us some indication as to looking at some of the compensatory mechanisms that might occur as a result of some potential issues going on with a patient. The supination pronation characteristic gives us some information as to where the foot is within, well, it's within that frontal plane, but we also get, it's a three-dimensional inertial sensor that gives us foot orientation. That's actually how we know when we look at things like steppage and clearance as well. So it looks at the angulation in the sagittal plane as to the heel strike as we get into the midfoot and then as we go into the toe off. And then, as I mentioned earlier, I can do a comparison. So I can take two different analyses and, maybe one that I took first with the patient, either when they came in, or maybe I did some baseline data with an athletics group or a school system or something like that. And then I can do a comparison. Maybe that wasn't a patient when I first analyzed them. Then they came in, they have a condition. Now we can look at the deviation in their movement patterns, or they were a patient when they first came in. Now we can look at the progression as a result of the interventions that we applied throughout the course of the treatment. And that's what the evolution does too. And that takes multiple analyses. It takes all of them that I did with that particular patient to do that comparison. So I'm gonna shift gears here. We're gonna go to the analysis here. So this is the online software. And yes, if you're an IT person, you see how many tabs I have opened up, and I know that's a no-no. But anyway, so we look at what we have available at the dashboard here. Let me just click on the home. So it tells me who I am, obviously, tells me I'm in the workspace, patients, equipment, membership, settings, and support. So that's just some of your basic information with regards to your plan and your program. So I click on patients here, and I had that first one. So I'm going to pick up. see Prue. And we're going to pull down here because I want to use this first one to sort of outline what we get from these analyses. 916. All right, so here's what we got to give you sort of an overlay. So 1 foot is in supination or inversion at the rear foot associated with supination, and then the other foot is actually in a dramatic position of pronation or eversion at the midfoot. And I'll let you kind of look at this and see if you can figure out which one. But again, so some of the first information that we see up at the top here is general, angular, type of view. So I can click on angular, which we're going to look at in a second, but the general is just sort of that, bam, that's that first easiest information to have an understanding. The different views that we have available to us, these are still being worked through, but to draw your attention to the custom view. So the custom view is interesting because maybe depending on your patient characteristics, some people you might be more interested in looking at contact time, flight time, whatever that case may be, especially if you're looking at changes to that specific deviation, right? In other words, a patient came in, everything looked good in their walking profile, so I don't need to keep pulling that up. I could just pull up, their steppage and clearance if that was the issue that we're really looking at, that was a problem. Also, from the 3 little dots over here, this is where I can choose and do a comparison between 2 different analyses. This is also where I can export and download the interpretation manual. So the interpretation manual is sort of your Bible as to what does all this mean above and beyond, what I'm going to talk about here. You can also get rid of or delete analyses if you don't want them in there anymore. I've done some fake ones, and I don't want that clouding up my space here, so we may just get rid of some of that. So we're going to look at, by default, the natural view. So this is, like I said, this is the general, and what we see across the top here is the symmetry, the speed, and the cadence. So a few things take into consideration as you see that there are some colors. So when it is in the green, it means that is considered to be a normative value. It's either normative based on that specific parameter and or normative relative to their demographic. In other words, their age, height, weight, and things like that. When you see it in the red, as you see down here, so it's at 1.7 miles per hour, it's in the red. And the reason is because the normative data, when you ask a patient to say, walk at a relatively comfortable pace that gets you to where you're going, that's estimated to be approximately 3 miles per hour. That's also associated with the metabolic equivalent, your MET values, for if you are going to say to someone, go ahead and walk, as your steps, your level of physical activity to obtain the necessary, amount of physical activity on a daily basis. That's a good thing. So related to that is actually going to be your cadence or your steps per minute. So you could see that here in the red. The reason it's in the red because average is considered to be 3 miles per hour. Now you see over here the cadence is in the orange. So the orange means that it's either on the low end or the high end, approaching outside of those normative values. So again, real quick and simple. So the symmetry here, you click on these question marks and it brings up a little drop down and it says, okay, this is the percentage calculated on the symmetry of the contact time of both feet. In other words, quick and dirty, this shows me the relative symmetry of contact time, right? And so it's showing it in green because my contact time is symmetrical. Now, it doesn't tell me that it's the appropriate contact time, but that's okay. It at least tells me that there's probably some normative approach to their motor control system. In other words, the right and the left foot are working fairly symmetrical to get them and move them across the horizontal. Then we look at the walking profile. So the walking profile gives me contact and flight, gives you your relative percentages, and then also shows you the relative percentage in the double stance phase. And so when we look at that, of the left foot, it's in the gold, but then you look over here on either end and you see this 15.4%. So that's the amount of time that you're actually spent in the double support phase. This is the stride length, 42 inches. So it gives me the stride length of both sides. And again, I can quickly look at that. And if I saw one was at 42 inches and the other one was at 27 inches, I can already see that there's a difference between the stride length, and obviously there would be a step and contact flight time difference between those two. The gait line, so the gait line is something that, some people aren't familiar with because that's often associated with like some of these pressure sensors that might be in your shoe, or if they're walking barefoot across a certain mat. And so what's interesting about this is it shows you that relative pressure distribution, orientation as you're going through that mid stance. So remember, I told you that one foot is going to be relatively pronated or inverted at the rear foot, and the other one, or externally rotated at the rear foot, and the other one was going to be supinated and internally rotated at the forefoot. So can you see which one it is? And the answer should be, well, I can see that the left, that person's really walking on the outside of their foot, and then on the right, they're really walking on the inside of the foot. Also, what you see here is the three different phases. You're loading, your flat foot, and your propulsion, and it breaks it down into a relative percentage. In other words, we know that there are some normative values as to how much of your time, your overall percentage of that time that you spend in contact in each one of those phases. And then if you wanted to, you just click on absolute, and it literally tells you with milliseconds the amount of time spent on each one of those. You'll notice this little triangular portion that's colored in here. That gives you the amount of time as well as the transition as I'm going into that first ray, because from normal, walking, we do transition and we typically go toe off on that first ray. The propulsion rate, so this is looking at the strategy compared to the right and the left, but utilizing the plantar flexors and the hip flexors, because those are the two factors predominantly associated with propulsion. In other words, going from that toe off into that swing phase. And what you'll notice down here is there'll be a little bit of an interpretation. So it's showing it's in green, and that makes sense. 2% over here, and it's within normal. So typically when we're looking at relative percentages with regards to symmetry or covariability, we're usually somewhere between 1 and about 8% on a lot of factors. And so that's why it's showing up in green. And then I have an opportunity down here. If I want to type in some comments based on the patient, you'll see something here in a second. So let's look at the angular view. And the angular view is what gives me that supination pronation angle. I'm going to click on advanced here, and that's actually going to show me what's referred to as the corridor. So in this graphical representation, you can see this green shaded area on both sides. That's the normative with standard deviation, the normative pattern of the position of the foot as we go through that contact phase. And when I'm outside of that, it means I'm outside of the normative value of what's been determined by the number of analyses that have been collected by the system to create that. Now, it sometimes throws people off is supination, pronation. Why does it look like I'm going into pronation? Well, it's not. It's actually showing the path as I'm transitioning from mid stance and what's going on with orientation of the mid to the rear foot. So more so looking at it as a rigid model. And then I want to show you these points right here. So you can actually put your cursor over these points, and it shows you the value at that particular phase. And if you look at these two lines on either side, these gray lines, right, it shows min and max, but that's actually, it's the minimum and maximum, or plus or minus 1 standard deviation. And so if you look at this guy over here on the left, you can see that they were spending, well, a lot of time over on, and as you saw in the gait line, on the lateral aspect of the foot. And then you can see over here that they're spending a whole lot more time on the medial aspect of the foot, because that foot was in severe pronation or calcaneal eversion, right? And so up top here, you can see heel strike, toe contact, heel off, and toes off. Again, just showing you those values, a quick and easy way to look at that. So this is relative to the horizontal, which is important why, you need to be walking on a flat and horizontal or level surface. And so a negative angle implies that there's going to be supination or inversion of the rear foot. And then a positive angle means that they're going in the opposite direction. And so, for example, you can see over here on toe off, the negative 21.9 degrees. And that makes sense because if you look at this graph, they're very much in that position with walking on the lateral aspect of the foot, which we also saw on the gait line. And then we see a positive 1.3 degrees, which means that they're actually in an everted position of the mid to the rear foot. Again, looking at that as a block model. Foot progression, angle. So now we're able to look at the orientation, because remember that the sensor, the technology in this guy is it's an inertial measuring unit, which means that it has gyroscopic and three-dimensional accelerometer to it. So we get all the different planes. So I can actually get to see, well, are they toeing out? So is there some external rotation, which there is normally when someone stands or walks for sure, but then there's also a relative amount of circumduction based on, you know, the construction of the anatomical features of the iliofemoral joint, right? And so we get both of those values. We look at that toe out effect, so the angle of external rotation, as well as the amount of circumduction. And as you might have guessed, there are some normative values of those guys too. The clearance and the steppage, so that's looking at, initially it's showing me the toe off position. How much into plantar flexion is that foot? And then how much of dorsiflexion am I into that position when I heel strike? And again, those values give us some indication as to the amount of plantar flexion that's going on, which also, relatively speaking, has an indication to some of the other kinematics or the joint positions at the knee and the hip. Same thing when I'm heel striking, right? And I'll show you an example here in a minute of why this angle makes a difference, because it will have an indication as to the type of foot strike pattern that I have. And that relative position of heel strike, again, also is indicative of what's going on kinematically in other parts of the body, especially at the knee and the hip. And then lastly is looking at the amount of clearance. So that clearance is foot clearance. And so that's a really good test if you want to know, you know, am I picking up too high or am I not picking up enough, which could be indicative of too much increase in hip flexion or knee flexion, possibly due to a pathological or an antalgic position, or I'm not clearing off enough. And that might be associated with, you know, another problem such as an older adult gait pattern to where, you know, that clearance could be indicative of a fall risk. So let me show you. I want to show you just a quick comparison, because the orientation of those sensors does make a difference. So let's see here, February 16th, 13/12, and 12/58. Okay, so what I did is I just pulled up another walking analysis, but I'm going to do something fancy here, and I'm going to click on compare. I click on compare, and it allows me to choose the other one, and I'm going to choose 13/12. That's this guy right here. So quick overview. So the 12/58, that is done with a relatively neutral shoe. So not excessive supination, not excessive pronation. And then the 13/12 is done with a shoe that has a very high arch to it. That's to help correct for someone who is an undersupinator or an overpronator, depending on how you want to look at it. And so this gives me that, again, quick comparison across the top with regards to symmetry, speed, and cadence. And these were both done at the exact same speed. So that's why the data looks very, very similar. And it should be, right? Because I really shouldn't be changing a whole lot with regards to, you know, if the length of the shoe is relatively the same, it's not changing things in flight phase. It's more going to change things in stance phase. And that's why when you look at this data, well, they're pretty darn close to being the same: stride length, contact time, flight time, and so on. Now I can click on the advanced, and that's what gives me more specific details with regards to those gait parameters. We'll shut that down, and then we're going to come down to, now we look at the gait line here, and this is where you see that dramatic difference, right? So over here on the left picture right here, that's the shoe that pushes you into more supination. And what it means is it has a much higher arch. So even initially, the sensor is actually going to be somewhat deviated. And so you want to know that to take that into somewhat of a consideration. So if you're looking at, complete level, horizon, and that's important to you to establish that, make sure that your patient is in a relatively neutral shoe. Or what might happen is, like in this case, it shows that this person, well, it looks like their under supination is not only corrected, but it's overcorrected. So I probably may not want to have this patient running in this shoe. The other thing that it does is it shows me those strategies in the hip flexors and the plantar flexors is relatively normal. And then I move to that other shoe and it starts to throw off their gait pattern. And all of this needs to be combined with whatever it is that you're doing with your patients and looking at your other assessment tools as well. But you can look at this particular patient and just look at the arch height on the left is much higher than the arch height on the right. So now we actually have an asymmetry in their supination, pronation, or inversion, eversion situation. So looking at these differences, and what you see is if you do these comparisons, you'll see it's about 6 degrees off all the way across, right? And again, that's because of that slight deviation or orientation. So I just take that into consideration when I'm looking at the shoe or whatever, whatever potential intervention that we're thinking about. But if I know I'm putting them into a relatively neutral shoe, and it's showing angles like, negative 26.2, then I know that that's more because of them and not just the orientation of the shoe, right? And so that just provides me a whole lot of information in whether or not I need to create some form of correction as an intervention with that particular patient. We look at the foot progression angles and we can see that they're fairly similar. And again, that really shouldn't change a whole lot because that's what's going on when we're looking at the that flight phase, right? So that's able to look at a comparison. Let me show you a running analysis really quick here. So this is a run analysis, and we get a little bit different data. So a run means that there has to be, that flight phase where there's an absence of that double support. So that's an important characteristic, and know that that's going to be at about a minimum of 5 miles per hour. And this was done on a treadmill, and that's why you see something very, very consistent here. But if you have someone run across the ground or on a track, you're actually able to see a little bit more of that deviation. So some slight differences, we see a strike pattern. So that's actually looking at the force when it comes to contact of the heel. It also shows us the relative orientation on heel strike, or that angle of attack at 11.2, 11.8. So what that tells me is that person's actually a heel striker as far as their running gait goes. So if you saw a difference in the angle position of that, then sometimes if you're working with a runner who might be a midfoot striker, you'll see a different orientation. And in fact, you just take that same person, change them from a heel striker to a midfoot striker, and you will probably also see some differences with the actual contact force. Again, it shows you the running profile, the angulation, with regards to supination and pronation. So now across time, I can actually look at some of this cadence and speed, and this actually shows me, at different points along this. Like I said, this person's on a treadmill, so it really shouldn't be that different. So let's go ahead and click on evolution. So on evolution, this shows me across the board, these assessments. So this is specifically on walk. I can click on run and it shows me the evolution of their run patterns too. And you can see, just put your cursor over these different points to specify where that evaluation had actually taken place. Let me go back to run here. So this was actually some of the things I did a little bit kooky. So that's why it looks so weird. This wasn't an actual patient, and that's but that's the type of information that you get and look at the evolution across time. So let me choose another patient here real quick. 1306. So this is an 83-year-old, a history of falling 6 times in the last 2 years, including a severe head injury that resulted in a concussion and needed some severe rehabilitation. She actually has pretty good symmetry. So if you walk, you could see that, well, it seems pretty normal in terms of her gait pattern as far as the contact time goes. She walks very, very slow. So this was actually across the ground. just because she's using a cane, so she's using a walking aid. And you can see that her contact time is a little bit longer. It's on the longer end of potentially what we refer to as normal. But you could see her stride length is 27, 25 inches. They're pretty close, and she's pretty short, so she's only 5'1", so she shouldn't have a really long stride length anyway. She does have a similar gait line looking at the right and the left, as well as some symmetry in regards to the right and left in the propulsive gait and the strategies that she uses in the hip flexors. But here's probably what's more important for this particular person is looking at this right here. So we can see that especially on that left, she has a relatively low strike angle, and it's pretty low even on this side too. And again, if you evaluate and you watch her walk, she has this really shuffling gait pattern. So she doesn't have, a lot of clearance. And I would call that barely, on the normal side. What we can do is we could challenge her a little bit more. If you had her on a treadmill and you speed that up, one of the things that changes with people like this is we do tend to see changes in their clearance height as you increase their challenge. I want to bring up a young person here. And so the young person, so I have two analyses. There's a shorter and there's a slower and a faster. So 12 years old, and we see that she has a fairly normal, gait pattern for the most part. But here's what's interesting. You see that, her gait line is fantastic. She's just a healthy person. But you see that, she has some compensatory strategies going on in the propulsion rate. And then let's go ahead and look at this guy right here. Angulation, fairly normal. But what you see is relatively low angulation here. I've got another little guy that I show too. And what's interesting is they don't normally walk on treadmills, right? Maybe some adults that use treadmills. So it does throw them off a little bit. So let them walk a little bit before you actually test them. Let me go back to the presentation here. So hopefully that gives you some indication as to kind of what the information is going to look like in terms of what we got. And then, to sort of summarize, we have, why do we use it? Well, it helps give us some condition information. I use it as a baseline, so I use it for the majority of my patients that come in. I also do a lot with athletics, and so we use it as a baseline to look at some of their symmetry. And I won't get into this a whole lot and talk off the cuff here, but looking at motor control strategies, like I said, for me, that's a big component to look at, the influence when someone has like a head injury, the influence that actually has on a gait pattern. I think the captain obvious is looking at lower extremity mechanics, or certainly the musculoskeletal, low back pain, neurodegenerative, fall risk, elderly. Looking at some of those compensatory changes that happen as a result of them getting older. I use it as a big part of the review of findings. So after I analyze a patient, where it fits in is I actually have a patient. We sit down, we go over all of their analysis, right? Over all the orthopedic neurological tests, everything that we've done with them. And I use gait as really that visual effect to show them how whatever it is that they have going on is influencing their mobility. And that's a really great tool because I tend to shy away from pain. Patients come into us and they're like, well, why are you here? Well, I've had low back pain. Well, actually, it's not pain that brings them in, statistically speaking. It's the level of disability. How long you had low back pain? About 10 years. Just getting in to see me? Well, no, it's so bad I can't do X, Y, Z. So it's actually a disability. So, pain is only going to get us so far. We do have to address it. Again, statistically speaking, patients want to make sure that we address it, but it's not the best indicator of reaching that maximal benefit. And especially if you're working with an athletic population, pain is a real poor indicator as to what exactly that they can find. So we use it to influence our intervention, but like I said, compliance. I can send this home with a patient and they can visually see this sort of thing. The other thing I like to do is relate it to some of these changes are associated and say, okay, look, you've got really bad, distribution of your weight pattern. We need to do something about that knee before it gets to a point where you might have to have too much degeneration that results in a joint replacement, for example. The sensitivity also in looking at variance. So I use the variance in that gait corridor a lot to look at some of the deviations. And one of the things that happens is when they're in acute pain, they have a high degree of variability. And then when we treat them, it happens to reduce. And then when we take people that are asymptomatic and we do stuff to them, that changes their motor control system, the variability actually increases. So we can actually use that sort of information in two different ways. And then for outreach, so I've been, well, that's how we grew up clinically and in terms of how we get some of our patients. But going to sporting events I think is a kind of a no-brainer, and even recreational runners typically want to do better. So I have a portable treadmill, but you don't even need a treadmill. That's the best part of this device is you can just have them go off and run a couple hundred yards, come back and do that evaluation. School systems. So actually doing some stuff in the school systems, either as part of their overall health assessment, or like I said, I do a lot with athletics, and I use gait as sort of a baseline, as well as some of the other things that we can utilize to inform some of our strength and conditioning. There are some other features that are coming out really, really soon. And then a big one is retirement community. So my mom's retirement community, for example, actually they have people come in and do balance assessment. Actually, I could do a gait assessment on those groups of people to provide some relative information. And it's a great way to get patients or clients, depending on what it is that you're attempting to accomplish. So I know we started a little bit late, so I missed the over under. So I'm gonna stop talking there. I know some of y'all have to go, but I'm happy to answer any questions you might have with regards to the device and the application. And feel free to reach out to us at a later date as well.
All right. Thank you, Chris. Before we leave, does anybody have a question quickly that you'd like to ask? If not, we'll follow up with all the attendees, and you're welcome to also email questions.
I do have a question, actually. I have a patient who I just recently got the Digitsole Pro, and so I've only used it for a few days. One of the patients I tested the other day is an Achilles tendon rupture who is just beginning to wean back into. She's been repaired. Actually had to do a flexor, an FHL transfer to do her repair. Anyway, with this, she's just beginning to wean from boot into a shoe, and it was very obvious. It was great to show her physician the dorsiflexion range of motion that she has progressed to the point where she has equal heel strike bilaterally. But because we haven't begun any really resistive training, she cannot plantar flex very well, and that shows up very specifically on the test. It showed up great. My question, though, is in the propulsion component, the little component where you have the muscular right versus left. I almost question if something in the software is reversed, and I wonder if somebody can speak to that or look at that, because it shows up as her propulsion on her non-involved side is in the red and her involved side is in the green. And I've noticed on a couple of other little tweaks, I wondered if there might be a flip in the software that is showing incorrect side.
Yeah. So so propulsion rate can have a different interpretation, whether you're a physical therapist, a podiatrist, or whomever. So the way that it's kind of set up and why you're seeing some of this now, if we think about that person trying to create normalization in their stride, because internally from a motor control standpoint, they are trying to make some of those compensatory changes. So they may actually have, a change in their propulsive pattern on that unaffected side too, especially because of either antalgics or abnormalities with that particular gait. So it's a, like you said, it's a combination of, a ratio of propulsive rate between the plantar flexors and the hip flexors. So if they're both low, they may actually come and show it as being somewhat normal to some extent. And then if we show based on, and I'll come back to this in a second, and then if we show even red on what's considered to be sort of the normal, that obviously there are going to be compensatory changes that take place on the contralateral side. And the other reason that it may show up normal is that propulsive rate is part of that ratio and has something to do with their stride length as well as their cadence. So on that affected side, they can kind of make that somewhat normal because their stride length and their cadence is such that it matches the propulsive rate for that condition.
Right. Right.
That makes sense?
Yeah, they're allowed to compensate enough or so-called cheat to make it look normal.
Yeah, and I'm with you. I find that a lot because, you know, and I use it even to show patients with low back pain, for example, is a lot of compensatory changes. Like some of them, they don't want to propulse off of the plantar flexors because that's a much longer lever. It creates more torque in the lower spine, and so they have compensatory changes in the hip flexors. But it's the complete opposite on the other side, and part of that is kind of that offset in the cadence and speed and stride length.
Okay. Her surgeon was blown away by the report, by the way. I went ahead and did some handwritten notes, printed him out a copy that she took to him. And her surgeon was blown away by this report. Absolutely loved it. So he didn't even know this type of thing was available. And he was thrilled to see this. So, and you know, second one I did, interesting. Again, I've only had this a couple of days, but we did a patient who has a foot drop, post-op back surgery, has a foot drop, and tested him with and without his dynamic AFO, and was great to see. I mean, you could just show exactly how much the dynamic AFO did for him. That it equalized right versus left, his dorsiflexion versus on the without the brace, he was at like 5 degrees on the involved leg.
Yeah.
So it was great.
Yeah. No, and again, some people and some of it we can't see. Some of it's, you know, obvious, but it's awesome to show the patients, some of the referring people, and, you know, what I find too is, you know, people are like, all right, I'll send them to Chris Prue because I know I'm going to get the data back and actually show that, you know, whatever it is he's doing is making those changes. And I think the other benefit too is the analytical representation, because when you send it to someone, it's so easy to read, and, you know, you can obviously draw attention to it. Yep. Yeah, that's awesome.
So thank you. So I'm enjoying it. It's just going to take a while to kind of get used to this interpretation. So.
Oh, it's a steep learning curve. You'll see.
Yeah.
All right. All right. Thank you everyone for attending, and we wish you a great day.
Thank you.
Thanks,
Bye-bye.
folks.